Assalamu alaikum warahmatullahi wabarakatuh. Hi everyone. I'm Dr. Shaima Araha, Assistant Professor of Pediatric Cardiology. Today I'm going to give you the demonstration about the cardiovascular examination. For the cardiovascular examination, it's subdivided into two categories. First, you have to do the general examination items that will help you in assessing the cardiac patient, and then you have to do local cardiac detailed examination. Before you put your hand on the patient, you have first to rapport with the patient and communicate and introduce yourself to the patient. ازيك يا محمد؟ اخبارك ايه؟
الحمد لله.
انا دكتوره شيماء رخا، انا استاذ مساعد القلب، والنهارده ان شاء الله هفحصك عشان نطمن كده على حالتك. تمام؟ ماشي. So after doing the rapport and communication with the patient, give yourself just a few seconds, take a good look at the patient. If he's assuming a certain position in the bed, if he is distressed or not, if he's conscious or not. So first I have to take a look at his belt again, if the patient is appropriate in his belt for the age or not, before I start touching the patient. And of course all the anthropometric measures, especially the weight and the height, must be taken before you do the detailed examination. When I first started the examination, I will start with the hands of the patient. وريني ايديك يا محمد بعد اذنك، الاثنين بعد اذنك. First, I will see the palm of the patient to check if the patient is having ossular node, genuine lesions, lesions of infective endocarditis, if the patient is having pallor, and you have to take a look at both hands at the same time for comparison. Then the back of the hand. وريني ظهر ايدك كده. Take a look at the nails for splinter hemorrhage, presence of cyanosis, presence of clumping. You have to take a look at both hands at the same time. Then you have to check for the clumping. ممكن تعملي كده، بص حط صوابعك الاثنين كده جنب بعض. جميل جدا. I have to check for the window sign. So the patient is having an obliterated angle because the patient is having a clumping in his hands. Then after checking these signs, you move on to examination of the pulse. For the younger children and infants, we check the brachial pulse. For older children and adolescent patients like our patient here today, we check the radial pulse. I will put my hand on the radial pulse and then I will start counting the heart rate for a whole minute, but for the sake of time I'm going to move on. And then you have to check, after checking the rate and the rhythm, you have to check the other hand as well and compare the pulse on both sides. And then you can compare the pulse in the upper limb and his lower limb to check the femoral pulse. انا هحط ايدي بس هنا على النط، ماشي، على رجلك، ما تخافش. And you check compare between the upper limb and lower limb for the radiofemoral delay to exclude the coarctation of aorta. Okay, take a quick look on the joints of the patient, especially we are an endemic area of rheumatic fever. I will take a quick look on the joint of the patient, of the upper limb. Okay, again the wrist, the ankle, and then I will check the brachial pulse, check the quality of the pulse, and then at this level you have to check the blood pressure of the patient. Now I'm going to move to the head and neck. بصي يا محمد فوق بعد اذنك، بص تعرف تشد كيف نعملها كده. خلاص شكرا. I have to check the patient eyes for the presence of jaundice, because the jaundice can be present in the patients with chronic heart failure and it's indicative of cardiac cirrhosis. And then when we are going to move to the mouth, you have to check for the presence of cyanosis. You have to check the patient teeth properly. افتح بقى كده بعد اذنك، طلع لسانك. خلاص شكرا. افتح بقى كويس نشوف بس اسنانك كده. I have to check properly for presence of teeth decay, because I am afraid of infective endocarditis in the cardiac patients. After checking for cyanosis and jaundice and teeth, then I'm going to move on to the neck. First, I have to make the patient look at the other side and check the presence of congested neck veins. And if there is congested neck veins, you have to comment if it's pulsating or not. And the patient must be elevated at 45 degree. After that, I will put my hand to check the carotid pulsation, the volume of pulsation. If it's pounding pulsation, I have to check if the patient is having hyperdynamic circulation. And then I'm going to check the suprasternal area for pulsations. Our patient doesn't have any suprasternal pulsation, presence of retractions, signs of respiratory distress. At this moment, I'm going to move on to the chest of the patient and the abdomen of the patient. Now I'm going to pair the patient properly for the chest and abdominal examination. First of all, I have to inspect the chest of the patient. If there is any obvious deformity, I have to comment on. If there is any signs of respiratory distress or retractions, I have to comment on. Before I'm starting the cardiac examination, I should make sure that the patient is paired properly, because I'm going to start with inspection. Now on the local cardiac examination, I have to start with the inspection, with inspecting the chest of the patient. First, I can see here presence of median sternotomy scar. In the cardiac patients, I have to exclude as well the presence of lateral thoracotomy scars. So I have to look properly on both sides of the chest for the lateral thoracotomy scars. Then I will move on to assessment of the pericardial bulge. I must go down tangential at the level of the chest, or I can move on to the foot of the bed and go down as well to make sure that I'm seeing both sides of the chest at the same time. Now, after assessing the pericardial bulge and the skin of the patients for presence of scars, you have to assess if the skin having any dilated veins or any abnormal rash. The third item in the inspection is inspecting the presence of pulsations. I have to look first for the presence of apical pulsation. In our patient here, I can see the apical pulsation on this side. You have to take a look at the epigastric area, the parasternal area, and we already had a look on the suprasternal area, pulmonary area here in the second left intercostal space and second right intercostal space, which is the aortic area, for presence of any pulsation. I can see here properly the apical pulsation, but I didn't see any added pulsations. Now I'm going to move on to the palpation step. For the palpation of the cardiac patient, you have to put your hand first to assess the site of the apex. I will put my hand from the lateral to the medial to get the lowermost and outermost point of maximal pulsation. I felt the lowermost and outermost point of pulsation here, so I will start counting the reps and the spaces to get what is the accurate position. I will get first the junction between the manubrial sterni and body. In front of it is the second left intercostal space, rib, then below it the second intercostal space, the third, the fourth, the fifth, nearly the sixth left intercostal space, just outside the mid-clavicular line. Here the apex just below the nipple, outside the mid-clavicular line. So the apex of the patient in the sixth left intercostal space, just outside the mid-clavicular line. After getting the apex position, have to put your hand and assess the character of the apex. Put your hand on the left parasternal to assess if there is right ventricular heave. And then you go to assess the pulsations. You have to confirm the presence or absence of any other pulsation in any other side. I'll start with the epigastric area. I'll put my thumb. I can put the 3 fingers to assess if there is epigastric pulsation. In the pulmonary area, in the aortic area, and then I will put my hand in the suprasternal area to assess if there is any palpable pulsation. The last step on the palpation is the presence of thrill. You have to put your hand so the heads of the metacarpals at the side that you can feel the thrill with. In the left parasternal, second left again, second right intercostal space, and maybe at the neck at the same time. After assessing the presence of thrill, you will move on to the percussion. Of course, the percussion in the smaller children and the infants is not done anymore. Recently, we don't do percussion for smaller children and infants, but in adolescent patient you can perform the percussion. To do the percussion of the heart, you have first to get to the right side and assess where is the lever. We will start in the second, third, fourth, till you get the liver dullness, and you go one space above the liver dullness and get from the lateral to the medial. Normally there is no dullness right to the sternum, but if there is any dullness, this indicates presence of atrial enlargement or pericardial effusion. You have to get to the second left intercostal space. If there is any dullness in the second left intercostal space, this is indicator of dilated pulmonary artery. Then the second right intercostal space, if there is any dullness, this is indicator of dilated aorta. And then I will get at the apex side, I get from the axillary line, from the lateral to the medial. There is dullness normally till you get the apex here. There is dullness, so I didn't get any dullness outside the apex. If there is any dullness outside the apex, this is indicator of presence of pericardial effusion. After finishing the percussion, I'm going to move on to the auscultation step. For the auscultation step, you have to start by auscultating the four primary areas. The four primary areas that I have to check or start with the mitral area, which is present at the apex of the heart. Then I have to move on to the tricuspid area at the lower left sternal border, and then the pulmonary area, the second left intercostal space, the aortic area, the second right intercostal space, the Arab's point, which is the A2 at the third left intercostal space. And then in the pediatric age, we have some additional points we need you to auscultate, like the left infraclavicular area to exclude the PDA. You can take a quick auscultation at the axillary area for the peripheral pulmonary stenosis. If you are suspecting mitral regurg of rheumatic origin, you have to move from the apex to the axilla to auscultate the propagated murmur. After finishing the auscultation on the anterior part of the chest, you make the patient sit down. And you have to auscultate in the interscapular area to exclude coarctation. And to complete your examination, you have to auscultate the bases of the lungs to auscultate if there is crepitation as a sign of pulmonary edema or in the patients with heart failure. And don't forget to palpate the sacrum of the patient to exclude sacral edema in patients with heart failure. And after you finishing the back of the patient, after finishing the auscultation, don't forget to palpate the liver, because hepatomegaly is a sign of heart failure, so you have to palpate the liver to exclude hepatomegaly, the left lobe, the right lobe, and the left lobe. Here in our patient, you don't have any hepatomegaly. And finally, I'm going to check his lower limb for presence of edema. Don't forget to assess the lower limb edema by assessing the bedding of the lower limb edema. You have to compress on the dorsum of the foot, on both feet, and then the legs, the anterior shaft of the tibia. Bilateral, you have to compress for 30 seconds and check if the edema is pitting or not. You have to take a good look on the nails, and if there is clubbing or cyanosis, quick look on the joints for presence of arthritis if you are suspecting that your patient is having rheumatic fever. Now I finished the examination, but you have to make sure in the OSCE exam you do full local cardiac examination. You have to do inspection palpation. In most of the patients, you were not asked to do the percussion, so you have to then check the auscultation of the patient for the inspection, comment on the presence of precordial bulge, presence of scars, presence of pulsations. On the palpation step, you have to comment on the apex, where the site of the apex and its character, if there is pulsation palpable, if there is thrill palpable. And on the auscultation step, you have to do a full comment for the presence of heart sounds, heart murmurs, and added sounds like clicks as well. And thank you for your listen.